Welcome to the deep dive. We are jumping straight into, well, a massive review of clinical medicine today.
It's a lot, yeah.
It's a huge amount.
Yeah.
We're dissecting some really complex, high-yield material across endocrinology, cardiology, autoimmunity, and prevention. We've done the heavy lifting of synthesis for you.
That's absolutely right. And our listener, you're dedicated to creating high-level medical educational content, so you need more than just, definitions.
Right.
Our mission here is to pull out those definitive clinical pearls and the critical contrasting features you need for, say, rapid differential diagnosis and effective management. We're trying to streamline that knowledge path.
Okay, let's unpack this and dive into those critical differentiators. We've organized material into 4 areas. First, we'll navigate some tricky endocrine pathways, pituitary and thyroid. Second, we'll decode the specific language of autoimmune serology. Then third, high-stakes cardiac diagnostics. And finally, we'll wrap up with essential preventive care. So, starting with the endocrine system. Hyperprolactinemia. This feels like a textbook example of how one pathology can present completely differently based on gender. A crucial teaching point.
It truly is. The most common cause is autonomous production from pituitary adenomas prolactinomas. They account for, about 60% of all functioning pituitary tumors?
Wow.
But what's fascinating is the timing of the presentation. Women, they typically present earlier, usually with these smaller microadenomas.
And that's because the hormonal consequences are just so much more.
They're immediately apparent, exactly. The hormonal changes, they cause amenorrhea or oligomenorrhea, often with galactorrhea, osteopenia. It drives women to seek help much sooner.
Right. You can't ignore that.
You can't.
Yeah.
Men, on the other hand, often present much, much later, typically with larger macrodenomas.
So it's a mass effect issue by then?
It's usually a mass effect issue. Things like visual field deficits, that classic bitemporal hemianopsia, or symptoms of hypergonadism. Because men don't have that clear, rapid feedback of the menstrual cycle, these things just grow.
That makes for a very high-yield contrast. Now, before we leave prolactin, there is a key piece of sort of cross-system knowledge you need for diagnosis.
Oh, this is absolutely vital. You always check the thyroid-stimulating hormone, or TSH, in any patient with elevated prolactin.
Why is that? What's the link?
The link is thyrotropin-releasing hormone, TRH. See, primary hypothyroidism leads to an increase in TRH, and TRH can then stimulate prolactin release from the pituitary. So you could mistakenly think you're dealing with a prolactinoma.
When really it's just the thyroid.
When in reality, you just need to treat the underlying hypothyroidism.
Moving down the pituitary, let's talk hypopituitarism. So, often caused by compression or necrosis, like in Sheehan syndrome, when that gland fails, there's a distinct order of hormone loss, isn't there?
Yes, the pituitary fails very systematically. The hormones are lost in a specific sequence. First to go is gonadotropin deficiency. That's your LH and FSH.
So sexual dysfunction, menstrual issues.
Exactly.
Yeah.
Growth hormone is next, then TSH, and critically, ACTH is almost always the last hormone to be lost.
That feels counterintuitive, given how critical cortisol is. But what's the major clinical trap here when doctors mistake secondary adrenal insufficiency for primary?
That's the deepest clinical pearl here. ACTH deficiency causes secondary adrenal insufficiency, so you get decreased cortisol, fatigue, weight loss. But the key distinction is that the salt wasting and hyperkalemia,
The really dangerous stuff.
the hallmark, often lethal electrolyte crises of primary adrenal failure, they're generally absent or minimal in the secondary form.
And that's because the main mineralocorticoid, aldosterone, is spared.
Exactly. Aldosterone production is primarily regulated by the renin-angiotensin system and potassium levels, not by ACTH. So, because the pituitary isn't making ACTH, but the adrenal cortex can still make aldosterone, the patient maintains salt and water balance.
And avoids that severe hypotension and hyperkalemia.
It's a life-saving distinction. It really is.
Okay, transitioning to the thyroid. Let's talk about the power of the physical exam. The way the thyroid feels under your fingers can instantly narrow the differential for hyperthyroidism.
Oh, it gives you 3 fantastic instant clues. If the gland is diffusely enlarged and painless, you are highly suspicious for Graves' disease.
Okay.
If it's diffusely enlarged, but, exquisitely painful, that signals an inflammatory process, usually subacute thyroiditis. And if the gland is enlarged, but you feel distinct painless nodules,
Plummer's disease,
or toxic multinodular goiter, exactly.
And what about the tricky one, the final differential?
Right. So if the patient has all the symptoms of hyperthyroidism, tachycardia, tremor, weight loss, but you cannot palpate the thyroid gland at all, you must consider factitious hyperthyroidism. The patient is secretly taking exogenous thyroid hormone.
And one final essential detail on management, specifically for a pregnant patient with Graves' disease. The medication choice changes mid-pregnancy, right?
Yes, and for anyone creating content on this, you really have to hammer this point home. It's a huge safety issue. Propylthiouracil, or PTU, is the agent of choice only during the first trimester.
Only the first.
We start there because PTU has been linked to fewer severe birth defects than methimazole early on. However, because PTU carries this rare but serious risk of fatal liver damage, you must switch the patient to methimazole for the rest of the pregnancy. The risk for methimazole is lower after that first trimester.
Let's pivot now to rheumatology, diving into acute arthritis. Synovial fluid analysis gives you definitive numerical cutoffs for diagnosis.
It's paramount, specifically the white blood cell count. We have three main categories. For septic arthritis, the count is typically very high. We're talking greater than 50,000 WBCs per cubic millimeter.
Wow. Okay, that's an emergency.
Immediate attention, immediate treatment. Then for inflammatory processes like RA or gout, you're in an intermediate range, generally 5,000 to 50,000.
And the non-inflammatory are just mechanical causes.
Osteoarthritis, trauma, those show a very low count, usually 200 to 2,000. But here's a key clinical trap to emphasize for your audience. Always check if the patient got antibiotics before the joint aspiration. If they did, that septic arthritis count might be artificially depressed, so your clinical suspicion has to remain high.
Moving to systemic diseases. Lupus. The sensitivity and specificity of serology, it's key, but the nuances are really complex.
They are. We teach that the anti-nuclear antibody, the ANA, is the great rule-out test for SLE. It's extremely sensitive. It's positive in over 95% of SLE patients. So a negative ANA is powerful evidence against the diagnosis.
But not very specific.
Not at all. A positive AMA can be seen in up to 10% of the healthy population and lots of other autoimmune conditions.
So we need those highly specific antibodies to confirm.
Absolutely. The two most specific for SLE are anti-dsDNA and anti-SM. For the clinician, anti-dsDNA is especially crucial because its titers often correlate directly with disease activity and with lupus nephritis.
And the others.
Well, if you see antihistone antibodies, you should immediately think of drug-induced lupus. It's present in 95% of those cases. And finally, anti-centromere antibodies are the signature marker for CREST syndrome.
Okay, let's discuss rheumatoid arthritis. What's the core pharmacological anchor for treatment?
The core treatment is still methotrexate, or MTX. It's the best initial DMARD. If MTX monotherapy fails, the standard path is to escalate by adding a biologic, usually an anti-TNF medication.
And before any elective surgery in an RA patient, there's a very high-stakes safety issue with the cervical spine.
This is a mandatory pre-op check. I mean, it's critical. Due to chronic inflammation in RA, this stuff called pannus can form at the C1 and C2 joints, leading to atlantoaxial subluxation.
So instability in the neck.
Exactly. And if a patient is intubated and their neck is hyperextended, it can cause immediate compression of the spinal cord. It's a disaster. So you have to screen them for symptoms like occipital headaches, upper extremity tingling, and they often need imaging before surgery.
Okay, finally in this section, the classic presentation of ankylosing spondylitis. What is the single most important clinical giveaway?
The textbook case is chronic lower back pain in a young man, 20s or 30s. But the pearl, the real giveaway, is the nature of the stiffness. Its morning stiffness lasts at least an hour, and it improves with exercise. That improvement is the defining feature that separates inflammatory back pain from mechanical back pain, which usually gets worse with activity. And it's strongly associated with HLA-B27.
All right, transitioning to high-stakes cardiology. Acute coronary syndrome markers. Troponins are preferred, but we need to understand the practical distinction between troponin I and troponin T.
Right, so both are essential markers for myocardial injury, but troponin I is often favored because troponin T is notorious for being elevated in some non-cardiac conditions.
Like what?
Notably, chronic renal disease, polymyositis, and dermatomyositis. So if you see a high troponin T in a patient with severe kidney disease but no clear signs of ischemia, you can't reliably say they're having an MI.
That is critical context. And the timing differences between troponin and CKMB mean both still have a use, right? Depending on what you're looking for.
Absolutely. Troponins stay elevated for a very long time, up to 2 weeks. This makes them great for ruling in an MI days after the event. CKMB, in contrast, normalizes much faster, usually within 2 or 3 days.
So it's good for reinfarction.
Exactly. It's still used when a patient has symptoms that suggest a potential reinfarction within days of their initial treatment. If that CKMB rises again, it strongly suggests new damage.
Let's shift to congestive heart failure. Differentiating systolic and diastolic dysfunction and identifying those crucial mortality-reducing treatments.
Okay, so systolic HF, or HFrEF heart failure with reduced ejection fraction, is a loss of the heart's contractile strength. The EF is below 45%. It's a pump failure.
And in HFrEF, we have specific drugs that are proven to reduce mortality.
4 classes, yes. And for you content creators, it's vital to be specific about the beta blockers.
What are they?
The mortality-reducing agents are ACE inhibitors, or ARBs, specific beta blockers, and it's only metoprolol succinate, carvedilol, and bisoprolol, and then aldosterone antagonists like spironolactone.
So why only those 3 beta blockers? Is there a reason?
Yeah, the reasoning comes from huge clinical trials. Only those 3 specific agents have shown a mortality benefit in stable HFrEF. The others just haven't, or they failed to show a benefit. So that specificity is a really high-yield teaching point.
Okay, now what about diastolic HF?
Diastolic HF, or HFpEF, preserved ejection fraction, means the pump, the contractility is normal. The problem is filling. The ventricle is stiff. Common causes are hypertensive heart disease, amyloidosis.
And the management is totally different.
Totally different. It's focused almost entirely on symptom control. Diuresis to reduce volume, strict blood pressure control. Those complex regimens that reduce mortality in HFrEF just don't apply the same way.
Our final section, preventive care. Arguably the most impactful area of medicine. Let's start with cancer screening, focusing on high-risk scenarios.
All right, so colon cancer. Average risk, colonoscopy every 10 years starting at age 50. But for high-risk patients, and this is the key knowledge nugget, we use a specific rule.
What's the rule?
If you have a single first-degree relative diagnosed before age 60, screening must start at age 40, or 10 years before the age the youngest relative was diagnosed, whichever is earlier.
That 10-year buffer is a fascinating idea. Why that specific interval?
It reflects the typical time it takes for an adenomatous polyp to progress to cancer. So by starting screening 10 years earlier, you aim to catch the precursor lesion, the polyp, before it becomes invasive. And importantly, those screenings are repeated every 5 years, not 10.
And the simple rule for cervical cancer.
Pap smear starts at age 21, and that's regardless of sexual activity, and it's every 3 years until age 65.
Yeah.
The emphasis there is on the age 21 start. We don't screen younger because it just leads to unnecessary interventions.
The stats on preventable deaths in adults from infectious diseases, they're staggering.
They are. Between 50,000 and 70,000 adults die every year from these diseases. This is why the American College of Physicians strongly recommends a comprehensive immunization status review for every patient starting at age 50. It's proactive medicine.
And for travel medicine, let's quickly hit the 2 forms of typhoid vaccine.
The preferred form is the capsular polysaccharide vaccine. It's an IM injection, single dose. It's robust, easy to give, and safe for immunocompromised patients, including those with HIV.
And the other one?
The other is a live attenuated oral form. It needs refrigeration, and it's contraindicated in immunocompromised people. So for your content, the IM form is the high-yield standard.
Finally, let's address the single most preventable cause of disease, smoking, and the 5 A's.
Right. The 5 A's give you the framework. Ask about smoking at every visit. Advise all smokers to quit. Attempt to assess their willingness. Assist by setting a quit date and using meds. And arrange follow-up.
And when you're assisting, you emphasize bupropion and varenicline. Why are they considered superior to, say, just a patch?
Well, they address the neurochemistry of addiction more fundamentally. Bupropion acts on dopamine and norepinephrine reuptake, which can mitigate cravings. Varenicline is a partial nicotinic agonist, so it blocks nicotine from binding, but also gives a little dopamine release. It reduces both the pleasure of smoking and the intensity of cravings.
One final quick note on injury prevention.
Injuries are the most common cause of death in people under 65. So a huge part of preventive care is just counseling on safety. Seatbelts, helmets, drunk driving, and also screening women for physical or sexual abuse.
So we've covered crucial differentiators in endocrine disorders, the language of autoimmune serology, high-stakes cardiac monitoring, and vital preventive screening schedules. This really should provide the perfect scaffold for anyone creating high-level medical content.
And if you connect this back to the bigger picture of genetic screening, You can see how dramatically some of these rare conditions shift our timelines. I mean, take familial adenomatous polyposis. It has a nearly 100% cancer penetrance risk by age 50.
100%.
So because of that, screening has to start extremely early. We're talking flexible sigmoidoscopy starting at age 12, repeated every 1 to 2 years. It just underscores the profound impact genetics has on when we stop observing and start intervening aggressively.
Okay, to reinforce this, especially those high-risk guidelines, here's a question for you. A 39-year-old woman is concerned about her risk of colon cancer because her father was diagnosed at age 43. Based on high-risk guidelines, what's the earliest age colonoscopy should have begun for her, and how often should it be repeated?
Right, so we use that 10-year buffer rule. Her father was diagnosed at 43, so 43 minus 10 is 33. Screening should have begun at age 33, and it has to be repeated every 5 years. That's the clinical application right there.
We hope this deep dive helps you feel truly well-informed and ready to tackle the complexity of clinical medicine. Join us next time.